now we can start.
Hi, everybody. Hello, everybody. Welcome to join the SMISS-AP webinar. Thank you, everybody, for joining the webinar out of your busy schedule. So today we're gonna have the very nice case presentation. We have prepared two cases resolved by the decompression probably endoscopically, and the case resolved by the MIS fusion. So thank you very much. I'm the Jin-Sung Kim practicing at Seoul Seminary Hospital. So we are having the discussion moderator, Dr. Raymond is from Hong Kong.
Hello.
Hello, Raymond.
Hi.
Can you hear me?
Hang on.
Okay. Great.
You cannot start your. Oh, yeah, I can hear you. Can you hear me?
Okay. Yeah, very well. It's very clear. Today we have the case discussion. Dr. Prashanth Rao, working in Australia, and we have invited Dr. Maria and Dr. Ayush for case presentation and the discussion together. So because of time constraint, so let us start the case presentation by Dr. Maria. Maria, please share your screen and get it started. Thank you very much.
Now you can see it?
Yeah.
Yeah, okay. So my name is Maria Pedraza. I'm neurosurgeon, and nowadays I'm doing the fellowship with Professor Kim in Seoul St. Mary's Hospital in Seoul. So the topic for today is how can you deal with symptomatic unilateral foraminal stenosis combined with the stable anterolisthesis. So we have a case. The patient has 65 years old, female. It's a normal weight. Past conditions that are important is hyperlipidemia, hypertension, and osteoporosis. And previous treatments that the patient already have is, it's a pain medication, nerve root block in many times in other hospitals, nucleoplasty, and intervertebral foraminal expansion. Occupation is lifting a lot of heavy things in a store, more than 50 years. And the main symptoms at the time that patient come to the OPD was right leg radicular pain, claudication after 15 minutes, and pain when is weighting things and bending. And in the sensory, we have that the patient has epistasia in L4, L5 dermatome. So the BAS score in the back is 8, and in the right leg is 8. ODI 64, CCI is 0, and BMD show us the diagnosis of osteoporosis. So at the physical examination, we didn't find any difficulties in the motor power. Everything was okay, but the main thing was in the sensory, as I already mentioned, L4, L5 dermatome epistasia in the right leg. So the medical record start in 2022. So in 2022 August, the patient started with right leg pain, L4, L5 dermatome, and was with tingling sensation, but without any specific trauma. Then the patient was admitted in another hospital in October at the same year. and she gets an intervertebral foramen expansion. At the time, the patient says that it was totally ineffective and the pain and the numbness persisted. So outside, they performed more blocks or neuroplasty. None of them were effective. So the pain continue become worse. And also the patient has more symptoms and get more symptomatic. And when she was standing, sitting, for lying down, the pain was increasing and persisted along the time. So we have in that moment for initial X-rays, this flexion extension image that we can see the normal like acceptable lordosis, but we can see the degenerative changes in L4, L5, also a decrease of the height of the intervertebral space L4, L5, and also listhesis L4, L5 that condition to a foraminal stenosis at the time. So it's important to us at this moment that if we already have instability is one of the questions that we should have in mind. And then we have another X-ray at the beginning of 2023 that it's almost pretty similar. The measurements didn't change a lot. So at this moment, the patient continued getting worse. This is the moment that we knew the patient. So we performed a new X-rays in 2023 in July, and we can find that the coronal vertical axis is 10.53, and the other measurements in sagittal view didn't change a lot. And the main things that we have to have in mind are showing in this slide. So we already have the spondylolisthesis that we already talked about, the decrease of the height of L4, L5. And also in this image, we can see the coronal view, and we can see that it's also lateral listhesis and also like a little bit scoliosis in this image. So we perform also an MRI. And in the MRI, the main changes in the right side in L4, L5, we can see the decrease of the height of the intervertebral disc. Also modest change in the intervertebral end plates in L4 and L5. And the most important finding is the narrowing of the foramen. So we can see in the upper levels, as I demark here, that the roots were free, but in L4, L5, we can see it's narrowing, not only because of the spondy, also because we have thickening of the ligamentum flavum and also the bulging disc in the right side mainly, but we also can see bulging disc in the central canal, but it's not so much. We confirmed the degenerative changes in the bone with CT. And in the CT, we can see in the coronal view that we have the osteophyte that is already kind of fused pseudarthrosis in L4, L5, and also the lateral listhesis that we already mentioned in the X-ray. And we also can see that the narrowing of the foramen is not only because of the bulging disc and the thickening of the ligamentum flavum that we already found in the MRI, but otherwise we have the bone that is also pitching the foramen in L4, L5 right side. So we decided to realize a SPECT-CT. And with the SPECT-CT, we can see that we don't have any uptakes in the SPEC in the joints. It's mainly in the intervertebral space, mainly in the right side, but there's no uptake in the joints in the posterior part of the column in the spine. So at this moment, the main resume is that we have the clinical examination, right leg radiculopathy, middle back pain, that the main complaint of the patient has always been the radiculopathy. And we found also that in the neurological examination, we didn't have motor weakness, only epistaxial L4, L5 right side. Foraminal stenosis that we already see in the different kind of image that we already take. So at this moment, this is the whole scenario that we have with this patient. So in the pre-op planning, we have to discuss which is the planning that we have for this patient. So this is the moment of the discussion.
Excellent case presentation. So it is time to discuss. Time to have discuss. Hey, Dr. Rao, please.
Thanks for the nice presentation, Maria. So I'll just think about two things. One is the fact that the predominantly radicular pain and mild back pain, and the fact that she's tried other interventions and hasn't worked. In the CT and the MRI, basically, there's hardly any disc height. So one of the concerns for just pure decompressions in such scenarios are the craniocaudal foramen height is very little. So it is not just the facetal hypertrophy or the superior articular process that's compressing. So if it's only radicular pain, I tend to do endoscopic foraminotomy, and for me to go is uniportal. But when there is craniocaudal compression, I constantly think about the fusion procedures. And the reason here being two: one is the lateral listhesis, and the other one is the craniocaudal compression. But I would have given the patient both the options. The reason that I would do endoscopic is purely for radicular pain, foraminotomy, foraminoplasty, but the durability of that, I'm not very sure. And the reason being is that of the lateral resthesis and the craniocaudal compression. So as long as the patient is happy to understand, and if the patient is equally good for both fusion and endoscopic foraminotomy, my preferred treatment in such a scenario would have been an Olive procedure.
So regarding the pain score before the operation, so Mario already posted the back pain score was not minor. It's so 8, and yeah, the leg pain score the 8. So I don't think that the patient back pain score is ever mild. So how do you predict kind of the improvement of the actual pain following the just decompression?
Sorry, are you asking how would you do the
So
chance
in
improvement?
case of improvement. So in case of the actual pain score more than 5 and 6, can you really predict the improvement of actual pain after compression? So you have done a lot of the endoscopic decompression. You might already experience sort of the changes of axial pain and axial neck pain following the decompression. What do you think of? Yeah.
You can get some moderate improvement, not excellent improvement, with just pure decompression. Some patients are very happy with that degree of moderate improvement rather than excellent improvement. So I always give them the option. Some patients prefer just to do the right thing, but some people are very concerned about a fusion procedure. So it depends on what they really want out of it. But I would always caution with this degree of bone scan positivity on the scan, the chance of improvement for axial back pain is not that high. In fact, there was a very nice paper from Korea. I was just reading about it. Vacuum phenomenon predicting the improvement of even radicular pain is much better with fusion compared to just endoscopic decompression.
And what I can recall is this patient is supposed to be lifting heavy weight, something like that. That was mentioned. So even in our setup, even the occupation or whatever the workload of the patient becomes important here when we choose between fusion and just a simple decompression. At least what we follow, if they are sort of are used to lifting heavy weight or something, they sort of tend to do better when we sort of give them stable spine. That has been our experience with such cases.
All right, Layman, do you have some comment for this case?
Yeah, can someone unblock my video, because someone stopped it. You can't see me, but I'm trying to start my video, but it's been stopped. Otherwise you can't see me. My comments would be similar. There's a concern about the mechanical back pain, which is presumably from the instability of the L45, which was positive on the SPECT scan. The concern is how much of the back pain would be alleviated by just a foraminal decompression alone, and also the height of the foramen, which is dictated by the pedicles above and below, might not be sufficient with a decompression unless we're resecting some of the pedicle, which is possible with the foraminoplasty. So going against that, she does have a poor DEXA result with a T-score of -3. So any implant surgery would be risky as well. So it may subside. We may be causing more problems by putting implants in as well, because so these are the concerns. So I think we just have to explain the options to the patient and see what she decides. The good thing about doing a decompression is that it does leave further pathways open. So if it's explained that the decompression doesn't work, so this is what I would normally do: explain to the patient that we could try decompression. If it doesn't work, we might need to go and escalate this to a fusion, or if she was younger, possibly a disc replacement even. But so that would be my scenario. I'd try to avoid putting implants in if possible, but if we have to, then because the symptoms are not going away, we may have to end up stabilizing you with some type of implant, be it a motion preservation or a fusion device.
Can I add something?
Yeah, Ayush, please.
Yes. What we have realized in these patients, especially if you look at the CT scans, the end plates are very sclerotic. So if you are planning to put like something like a lateral or something, in spite of having DEXA, they are normally, in spite of having poor DEXA, the end plates are normally very rigid because that is because of the rubbing and stenosis. And most of the time, what we have seen is you can get away with putting a big cage, and that has been our experience. So much so that even in these, specifically this case, when I look at the CT and see those sclerotic end plates, I prefer to do a OLIF.
Yeah, that is very important point for decision making. So regarding the classification of degenerative spondylolisthesis and sort of the combined lateral subluxation of the spine at the same level, so do we have really nice classification system for that? So I remember, so you know, so from India, your group have the great the paper for classification. I cannot remember you guys have the kind of the modifier for lateral subluxation or not. Do we have the really good classification system for this kind of case? I'm not sure we have. So if this patient were your patient, what's your best the first recommendation, Dr. Ayush and Rao,
For me,
regarding yeah.
so for me, of course, we always give them an option. But if patient is fine with to choose either fusion or a decompression, my preference will be a fusion. Preferably a OLIF will do the job for me. I believe if you put it right, it will really open the whole thing. And considering what we have, it will sort of solve both the problems of back pain, which are insignificant, as significant as leg pain. So I think that is where I will be. But for whatever reason, patient doesn't want a fusion surgery, I will prefer a endoscopic decompression and just do the foraminal.
How old was the patient, Maria? Remind me again.
Age.
60 something.
65?
65, precisely.
65.
5 years old. Oh, so it's almost like a 50-50 chance. My preference at the moment is I would offer both, and I would tell why each one of them. If a foraminal block improved both back and leg pain significantly, then I would offer foraminotomy, with the caveat that if foraminotomy doesn't help, I would do a fusion, and if fusion, it's going to be OLIF. If the foraminal injection improved leg pain only and did not improve the back pain, then I would offer OLIF as the first procedure.
So regarding the improvement following the injection, because this lady already have gotten 20,000, 20 or 30 times of the epidural injection, including the interventional, the pain treatment, neuroplasty, and foraminal arterial lysis.
Yeah.
As far as I remember, these patients just improved the transient improvement, or in case of advanced stage of stenosis, nothing for improvement, right?
No. The only thing I use it as a diagnostic tool. I'm not saying that this is going to be. So what I tend to do is I would ask them, the foraminal injection, even in the short term, did it improve both back and leg pain, or just the back, or just the leg pain? If it is pure leg pain but the back pain remained the same, I would offer fusion. Or I would offer fusion if the patient preferred to have one operation rather than have two different operations.
Yeah.
Now, just one question for me. What is foraminal expansion? What do you guys do?
This is the kind of the translation issue. There's foraminal expansion is the needle base
Yeah.
audiovisualizes along the foramen. That is a pain procedures done by the pain doctors,
Okay.
not the expansion.
Okay. Okay. What would you have done, Prof?
So, okay, Maria, please show us the case resolution.
Okay.
Yeah.
So after the image, the patient was admitted for surgery. So of course, Professor Kim has in mind all the suggestions that you already talked about. So that's why we put this only the compression, also fusion, but depend of the whole scenario of the patient also. And we decided to resolve the patient with endo transforaminal decompression. So this is planning before surgery. So this is the way that we took the measurements before surgery and planned the triangulation because it was biportal surgery. And in this image, we can see already the patient in prone position. We use navigation to do more precisely and have a better navigation through the foramen. And we can see that also we take the measurements that we already have in the CT in pre-op planning. And this is the video clip of the surgery. So all the structures are demarked in the video, so we can see the SAP drilling, the facet joint, the foraminal ligaments that we can find, EP in this right side. And with the navigation, we are controlling every single part of the foraminal area in order to get better decompression. So as we can see, the navigation in this case is really important because all the structures are normal structures that we can find easily in a patient that didn't have this kind of spondy are lost. So it's not so easy it's easy to get lost. So the navigation is also used and is really handy for the surgeon in order to find the true space of the foramen. So nowadays we can see the bulging disc that was also pushing the root. And in the right side of the screen, we can see that it's already the root, and Professor Kim is already doing a discectomy that in order to give more freedom to the root. So after surgery, we realized control of the X-ray, and the main find is in the coronal vertical axis. We can see that it's already an improve from 10 to 7 almost, and also there's also improving the lumbar lordosis. That's like the main findings in the X-ray. And in the MRI control that we perform usually in this institution, we can see that there's already the space of the pediculectomy, but we can see that in the next image, in the next slide in the CT. But it's already open, the foramen, and we can see that the height of the measurement of the normal root is already better if we compare to the previous image that we already see before. And the main changes in the CT in the bone structures, as we talked during the video, so we can see that we have improvement, a huge improvement of the volume in the foramen. And we can see the partial pediculectomy, and also we can see and we reassure that the decompression was done, because this is the previous image and this is the post-op image. So there's not also the improvement in the sagittal view, but it's also the improvement when we can see the axial image. So what about the satisfaction with surgery? So we perform some scales and ask to the patient how he feels after the surgery. So the satisfaction score was over 80% in the first day, and the next day is 90%. And what about the pain? The back pain is 5 in the first day, but I'm sorry, his right side, it's 0, didn't have pain in the right side. So in the follow-up, we can see the skin incision that is really minimal. And the patient already says that she can walk more than 30 minutes. As we can remember at the time, she already have claudication of 15 minutes. So she's already improving. And she has a little bit tightness in the right calf, but it was much improved. So we have another X-ray. So in this image, we can see the changes through the time. And it's pretty similar. We didn't see huge changes. And this is like a graphic that I realized in order to see that the changes of the pelvic tick, lumbar lordosis, and sacral slope and pelvic incidence is not so much. And we continue in OPD, follow the patient and continue improving, and also doing more exercise, indoor exercise and outside exercise, and also aquatherapy. And the last time that we saw the patient was in January. In January, continue with the therapy and already ambulation for an hour without claudication. And the backache is on and off, but it's acceptable. The patient says that it's decreasing and it's tolerable. And other things that we want to share with you is that there were no changes at the time in January in the listhesis in sagittal view, but we can see that also the patient get an improvement in the coronal deformity. So nowadays the patient is better with the procedure that we perform. So take a home message is that endoscopic foraminotomy achieves satisfactory outcomes without sacrificing segmental stability, and patient-specific tailor approach execute the surgical strategy.
Very nice solution
Nice.
there.
Nice presentation. So regarding the surgical technique, it's not a simple foraminotomy because I resected a part of pedicle to, as we know, the craniovertical narrowing of the foramen is too much. So without simple dorsal decompression, just like the routine foraminotomy, it might not work for elevating the pain enough. So I try to make the more space craniocaudal expansion. That is why I remove the part of pedicle L4 cranial side. The caudal side. I remove the disc and part of the kind of the bony spur that is the that allows the exceeding nerve getting released a little bit more than the usual foraminotomy.
So, Professor Luke, very nicely and elegantly done for sure. In your hand, it really worked and you had all the tools to do it. But what will you suggest a person who doesn't have the same technology like you and wants to do the surgery? What will be his option?
And actually, when this patient lady came up to my clinic, I didn't, I was not able to suggest decompression first because this is a little bit the far, it's beyond the usual indication, right? So patient have the recesses and lateral subluxation, a lot the axial pain score. So the decompression still have the risk of the failure, right? So I had to respect patient unmet need. Patient really want to get decompression, selective decompression. So that's my the is one of the decision process in real practice. The reason why I did it with the bipolar, not the unipolar. As you know, I'm a big fan of the unipolar, but but sorry, just play with me. So, but so unipolar. So even with the expert hands, it's technically not easy to manage the craniocaudal expansion, partial pediclectomy, right? So bipolar, it is for surgeon, it is more convenient to manage the instruments, right? We can bring the drill, we can bring the osteotome, we can retract the nerve with your left hand and right hand. So you can manage all kind of the instruments, just like exactly the same performance of microscope could be possible. That is why I bipolar instead of unipolar, right?
That's what I was going to ask you. It was going to be hard using uniportal.
Yeah. So I can say I'm gonna try. I'm trying to find the indication what bipolar really works well, what kind of the disease really good indicated for unipolar, right? So this
Yeah.
kind of the advanced stage of the stenosis, kind of a lot of bony spur, I believe the bipolar works much well.
Yeah.
That's my personal opinion.
No, my another question to you would be, what would be the durability of the symptom relief, do you think?
Yeah, this patient will be coming up next month, November. That's
Yeah.
gonna be 1 year follow. But my researcher already contact before the case presentation. She is still doing well. So I actually have a lot of similar cases like this.
Mm.
So over the top decompression, unilateral foraminal decompression in case of the foraminal stenosis. So one of the knowledge we haven't solved the knowledge yet is kind of indication of decompression alone in case of the stable, especially stable anterolisthesis, in case of the stable kind of laterolisthesis. So my mission is to find the indication really suitable for decompression alone. So as you know, these patients' actual pain improve a lot too, right? So one of the mission is to find how much actual pain could be improved following the decompression alone, unilateral, the unipolar, bipolar, or even the microscope, either way, right?
Yeah, it'll be a good study to just look at the back pain improvement. Yeah.
Thank you. So it's gonna be, yeah. This case draws a lot of the question and debate. Let's move to the second question. Second case. Dr. Ayush, please go further.
So thank you, Dr. Duke and everyone. And again, the topic remains the same, and I will be presenting the second case. So I am Dr. Ayush Sharma. I am a consultant spine surgeon based in Mumbai. And this is the patient. He is a 52-year-old male, a heavy industrial worker, and he has been suffering from back pain and left lower limb radiculopathy for 6 months. He has tried everything, including the blocks, the physiotherapy, and both a L4 and L5 block has given him a partial relief. But because of the nature of the job he's doing, is really terrible since last 1 month. He has both the leg and the back pain. The VAS score for back pain is 7, and on clinical examination, there is no motor deficit. There is a sensory deficit in left L4 and L5 dermatomes. These are his standing X-ray. If you look at, as you can look at him, he is pretty well balanced when it comes to standing X-ray. There is a grade 1 stable listhesis with some difference in angulation when we have put him on the stress X-ray, and these are again standing stress view, which we believe gives you a better idea if you can get one, because it really puts the pressure on the back when you are performing this. So these are not supine but standing stress views. So these are the cuts. You can, as you can see here, L4-5 is the culprit. We believe that left facet is what is causing the problem. But don't forget the right side, there is a full facet sign on the right side. And just to go through the images, these are the series of images which you can see on, these are the sagittal view, and if you look at the central canal is almost free, and everything which is happening, the compression is only unilateral, and again, these are the axial cuts. Again, you can see that it is mostly, there is some flavum hypertrophy, but mostly it is the left facet which is sort of causing the compression and leading to the problem. So again, he has tried everything. He has been put on all the medication, physiotherapy, root blocks, and he is a heavy industrial worker, which means he really needs to carry those weights. And this present problem has sort of aggravated over last 1 month, and it is not allowing him to really perform his duties. So his main, when he came to us, his main thing is, Doc, I cannot take it anymore. I really want to go back to my job because this is really killing me, and you need to find a solution which allows me to really do what I do. So again, our options are you can have a tubular endoscopy, uniportal, biportal decompression, or considering whatever he has, we can offer him a sort of a fusion surgery which can be between a TLIF open MIS or maybe a OLIF. So this is the summary of the case. So your thought, Dr. Rao?
So what's his BMI, Ayush?
So his BMI is pretty okay. He's not very fat. It is he's moderate.
Yeah.
He's an active person, and he needs to really work.
Yeah. So first thing, as you rightly pointed out, the radicular pain is likely from the impingement from the facet hypertrophy and ligamental hypertrophy. And I often find that sometimes MRI is less obvious compared to their pain scores, mainly because as soon as they're upright, it just gets worse. So that makes that's easy to decide that that's the source of the problem. The source of the back pain, though, I'm wondering, it's less discogenic and it's more facetogenic, and the spondylolisthesis, as you rightly said, is stable and grade 1, and the disc height is reasonably similar to what it is at the level above, so preserved disc height. So in such a scenario, I personally would do an endoscopic decompression on the side of the pathology, which is symptomatic, and for the back pain, if there is any residual, I would then do radiofrequency ablation, whether it is endoscopic or traditional. And one of the reasons I would actually just do endoscopic decompression is being a worker who is involved in very physical activity, they can get back to that quicker with endoscopic than a fusion. So those would be my reasons.
Dr. Liu, your thought.
So, Rao and the Ayush, when you want to go further with decompression alone, what is most important radiology parameter? So I see this case regarding the facet tropism is not horizontal, right? Yes, it's very acceptable range of the facet tropism. Do you really consider this kind of the facet tropism when you decide if the surgical procedures between the decom versus fusion?
Yeah, if it's more horizontal facet, the likelihood of worsening of spondylolisthesis is much lesser than a vertically oriented facet. So I do think about it.
Yeah. I think in the practice, I explained the both kind of surgical procedure between the decompression versus diffusion. Personally, I'm a little bit gravitated towards the decompression alone with the full endoscope. So this case is one of the best case indication for full endoscopic anterolisthesis decompression. Right. So personally, I prefer the decompression. Raymond, hi.
Yes, I'm here.
Do you believe this is can be indicated for artificial disc replacement? Please share your experience for kind of. Yeah.
Sorry, could you repeat that again? I just had a call come in.
So indication for artificial replacement.
Yes,
You
would.
believe this is, yeah.
I
can
would
be
do
treated
TDR
well.
because he's young,
Yeah.
assuming he's got good
Yeah.
bone density. The adjacent discs are not healthy, so we have to be aware with any fusion. Are we setting off the adjacent disc? Because he's got 4 out of 5 lumbar discs are degenerated.
Yeah.
So a TDR, just by the same principle as an OLIF or an ALIF, just by ligamentotaxis, would decompress the lateral recess easily. And it would offload the facet and protect the adjacent levels. The only concern is the compliance with the TDR rehab afterwards. So some patients do not comply, and we have problems with the TDR because it's not fully incorporated before they start moving, and osteolysis and other problems can ensue. But a TDR would work well for him. And because he does have an unstable, when he goes into flexion, this disc does translate quite a bit. And this will not get better if you do any decompression. It would probably get worse over time. And this disc would continue to degenerate. And he's still in his 50s. So he's still got another 15 good, working years. He's in manual work, is he?
Yeah, he's a heavy.
So yeah, I would probably just not want to exacerbate anything by fusing anything, because it's likely that he would probably get an adjacent segment, given that there are already 4 damaged discs in the lumbar spine. So fusion we have to be quite careful with, and the decompression, is it enough to deal with this slightly unstable disc now? Because the pathology is always in the disc first, and facet joint problems always are consequent to increased stress placed on the facet joints from a damaged disc. So we know that from the basic mechanics, that the disc normally supports 80%. A healthy disc normally supports 80% of the body weight, but when it becomes degenerated, the pressure loading on the facet joints doubles or triples. So that's what's happening here. And the facet joint issues are only secondary to the disc problem. So by replacing and stabilizing the disc, we probably give him best prognosis. So a disc replacement, assuming he has good, and he fulfills all the parameters, so good bone density, then should work very well for him.
Yeah. Because
Raymond,
I assume you are the big fan of the artificial disc replacements. So my question for Raymond, do you believe this patient has the instability or not?
He has slight instability of 4-5. We do normally see translation in flexion in a healthy 4-5. If you look carefully, in anyone who has a flexion view, someone young, the 4-5 does translate the most, because those facet joints do allow a certain degree of translation. But I think his 4-5, even in the lordotic view, is also translated. So it is slightly unstable to start with, and that's probably what's causing the problem.
Yeah.
how is it with facet arthropathy, Raymond, and disc replacement?
I've actually got patients that I've done disc replacement for, and we always repeat the MRI at about a year, just because I'm curious and just to see how they're doing. And I've seen so many facet joint effusions disappear, facet joint remodeling, because the facet joint is a vascular structure. It can actually recover. So we do see remodeling of the facet joint, and just like an OLIF or an ALIF, we see increase in foraminal dimensions and canal dimensions with time. A lot of it's just like stabilizing an unstable C1-2 in the cervical spine. Once we stabilize it, the pannus, the extra material, just absorbs over time as that segment restabilizes. So it does remodel. So the facet joints do remodel over time. And the subluxation, because we're restoring the disc, the facet goes back to its original orientation, and it restabilizes. If there are any facet joint issues, we can usually treat them with medial branch blocks or radiofrequency if there is facet joint, or even a debridement if necessary, to treat any sort of facet joint pain that might ensue after a total disc replacement.
Cool.
So yeah, so I guess you did a fusion for him.
So basically, we give him both the option. We do have good experience with endoscopy as well. So what we told him is your options are between these two. We don't do TDR, so sorry about that. We didn't discuss that part. But the option we gave him this, and we told him that there is some listhesis, there's a stable listhesis. Your back pain component could improve, and after discussing everything, he sort of chose for a fusion surgery, and this is what we did. We opted for a MIS TLIF. This is how it was done, the classical thing. But I thought that facet is a big problem here, so we sort of took out the whole facet from one end to the other end, because this is what was done. The whole thing, we thought that it's better to get the whole thing out, because I personally believe it was the facetal component which was the culprit, and this is how it looks like. You can see the root and the dura, and we sort of, because there was a phlegm hypertrophy bit when we went in. It was more than what the MRI showed. We sort of added a decompression as well. It was sort of a bit surprising, but there was a component of phlegm hypertrophy as well, which was not very obvious on the MRI. And this is post-op X-rays. You can see it's well balanced, and this is its standing X-rays in, and this is a CT scan. You can see that the whole of the facet on one side, we just took it off, because I didn't really want to have any problem with this. And he went on to do very well in terms of both leg and back pain. He has returned to work in 3.5 weeks, and that is, he was not, the BMI was low, he was very aggressive on physiotherapy. As of today, his VAS for his back pain is 2, leg pain is almost gone, it's almost like 0. Of course, we do understand the problems of ASD and everything, but what we have tried to do is get a good balance, which might sort of help him to have a longer period before the adjacent levels sort of degenerate. So that is what we did. And of course, and this is again shows good position of the cage and bone graft and everything. And before I finish, I do want you guys to come to Mumbai in 2025, which will be the SMISS-AP annual meeting, combined with two of the biggest societies in India, which is the MESSER, which is the MI Society for India, and Bombay Spine Society, which I belong to in Bombay.
Great. That's great. It was 2019 when I visited India last time.
I've never been to
So
Mumbai.
anyway,
Me
you
neither.
should.
We'll be going. We'll be coming.
Yeah, great. Yeah, great city. So I have the quick question, Ayush. So you usually follow unilateral cage placement?
Yeah, so most of the time unilateral. I don't mind going bilateral if I have to. It's like depending if I have to, for whatever reason, if I have to do a T-lift and I cannot do anterior or O-lift, and I really want to get a lot out of that level, I will go bilateral, take everything out from one end to the other end, and release as much as I can, because I believe it is the release which is much important. T-lift is not a bad surgery. It is the way we do it, sometimes looks a bit bad.
How do you decide between doing T-lift versus O-lift?
So I see, for me, whatever is simpler. I have very, maybe you can call me a lazy surgeon, but I always believe if it is simple, you will likely to have less complication. It is a very basic mindset. If I believe O-lift is a simpler surgery for that patient, you have a decent corridor, I will go for O-lift versus T-lift. Again, even the other thing you decide, again, is if you really, what you are planning for, it's a if I'm doing multi-level for whatever reason, if you have to do more than 2 level, again, I prefer O-lift, because, again, it's a simpler surgery. Multi-level T-lift is a complicated surgery compared to multi-level O-lift, at least in my book. every time I decide what I can do the most simplest, and that determines my surgery. And that is how I have been.
Yeah, that's great. So, any other comments among us?
My question, Prof, I went through quite a bit of literature review trying to see if there is any evidence for the exact topic we had. Unilateral foraminal stenosis, stable anterolisthesis. So fusion was endoscopic decompression.
Yeah.
Did not find a particular topic.
No.
It's always a combination. I've seen lumbar stenosis, spinal stenosis, fusion versus endoscopy. Or, you know, a combination. There is no foraminal stenosis anywhere. So it's time for you to write one.
Yeah, sure. It's gonna be great. So one of the hidden reason why I embrace this kind of the topic for SMISS-AP webinar. So I really hope you guys keep your eyes on this specific pathology, just in case of unilateral radiculopathy dominantly from the foramen and radiculosis. I'm gonna really highlight the role of decompression, more specified endoscopically. So I also have the limited cases from my perspective, but if you have a little bit more cases like mine cases, so you can make this great job uh, published together, right? So let us go further with this kind of the new evidence is really the affordable and beautiful job for our patient. Yeah, that is one of my mission. But I still believe the compression is final way to go. So when I explain the endoscopic decompression, micros decompression for foramen or radialis combined with the pathology, I always explain the reoperation risk is going to be up to 10, at least 10, up to 15% once the patient accept this kind of risk. That's going to be a great job, great deal with the kind of pathology. Okay, thank you very much. Today we had a great discussion. So if you have any comments or question, so it's time to wrap up because the Korea is 9:09 and the Ayush might be very busy time.
It's okay.
Okay, thank you for joining our busy schedule. Please.
Bye. Have a great day.
Yeah. Yeah. Let's have an in-person meeting in Mumbai next year.
Fantastic.
Everybody.
Yeah.
Thank you all.
Thank you all.
Thank you, everybody. Thank you, Maria. Thank you, Ayush and Rao and Raymond.
I'm here. I just can't see me. Okay.
Thanks,
Okay,
Raymond.
thank you.
See you.
Bye-bye.
Bye.